Good morning. I will start obstructive lung diseases part 2. We will discuss today chronic bronchitis and emphysema. The intended learning outcomes for each of chronic bronchitis and emphysema, you should be able at the end of this lecture to define the disease, to explain the pathogenesis, to describe the pathologic features of each disease, identify the clinical picture and list the complication, and also correlate the pathological features with the clinical picture and complication of each disease. In the previous lecture, we classified the diffuse lung diseases into two main categories, obstructive and restrictive diseases. Obstructive diseases means increased resistance to airflow due to partial or complete obstruction, while the restrictive lung disease is reduced expansion of lung parenchyma with decreased in total lung capacity. Again, the obstructive lung diseases characterized by increased resistance to airflow due to partial or complete obstruction. The causes of these diseases after exclusion of tumors and inhalation of foreign body are chronic bronchitis, emphysema, bronchial asthma, bronchiectasis, bronchiolitis, and cystic fibrosis, while the restrictive diseases characterized by reduced expansion of lung parenchyma with decreased total lung capacity, occur in two conditions, acute and chronic interstitial lung diseases, and extrapulmonary disorders. We will start by the chronic bronchitis. The definition of chronic bronchitis is persistent productive cough for at least 3 consecutive months in at least 2 consecutive years, in the absence of any identifiable causes. This is a clinical definition. So, chronic bronchitis is persistent productive cough for at least 3 consecutive months in at least 2 consecutive years. Pathogenesis of chronic bronchitis. The characteristic features of chronic bronchitis is hypersecretion of mucus that begins in the large airways with infiltration of inflammatory cells like lymphocytes, macrophages, and neutrophils. This disease starts in the large airway like the trachea and bronchi, leading to hyperplasia and hypertrophy of the mucus glands, then affecting the small airway like the small bronchioles, leading to metaplasia of mucin-secreting goblet cells, resulting in small airway obstruction. The main cause of chronic bronchitis is continuous exposure to irritants as smoking or air pollutants, leading to irritation of both large and small bronchi. In the large bronchi, there is hypertrophy and hyperplasia of the mucus glands, and in the small bronchi, hyperplasia of the goblet cells in the surface epithelium, and also metaplasia of the respiratory epithelial cells to goblet cells. So we call it goblet cell metaplasia, occur in the small bronchioles. Due to irritation of the airway, there is inflammation of the wall of the bronchi and the bronchioles, leading to fibrosis of this wall. So the lumen is filled with mucus due to hyperplasia of the mucus glands and goblet cell metaplasia, and due to inflammation of the wall with fibrosis, leading to narrowing of the bronchi and the bronchioles, with mucus, intraluminal mucus hypersecretion, causing chronic airway obstruction. The pathologic features of chronic bronchitis, the gross picture, the mucosal lining of the bronchi is hyperemic and swollen and covered by a layer of mucinous secretion or mucopurulent secretion. The microscopic picture, The wall of the trachea and the bronchi show hyperplasia of the mucous glands with increased what is called reed index. We will see it in the next slide. Small bronchioles showed goblet cell metaplasia, increased mucus secretion, inflammation, and fibrosis. The inflammatory infiltrate formed of neutrophils, macrophages, and lymphocytes. This is what's called increased reed index in case of chronic bronchitis due to hyperplasia of the mucous glands. What is reed index? The definition of reed index is the ratio of mucous gland layer to the thickness of the wall between the basement membrane and the cartilage. Here is the basement membrane, and this is the cartilage, and this is the wall. The ratio between the mucous glands to the whole thickness of the wall, we call it reed index. Normally, this index is less than 0.4. And in case of chronic bronchitis, there is increase in this index, as we see here, increase in or hyperplasia of the mucous glands, so the thickness increased. The thickness of the mucous gland increased in relation to the whole wall. In case of chronic bronchitis, we can see also squamous metaplasia due to chronic irritation. This is the normal respiratory epithelium, and this is the squamous metaplastic epithelium. This diagram shows a microscopic picture of chronic bronchiolitis. We have here the lining epithelium showing goblet cell metaplasia and also focal squamous metaplasia. The mucous glands increased in size and shape with inflammatory infiltrate in the lamina propria. Chronic bronchiolitis, it's a small airway disease characterized by goblet cell metaplasia leading to mucus plugging, chronic inflammatory cell infiltrate, fibrosis. The fibrosis that lead to luminal narrowing and airway obstruction. This condition can coexist with emphysema. Cor pulmonale may develop in the long-standing and severe chronic bronchitis because of hypercapnia and hypoxemia, and in severe cases, cyanosis may develop. Why cor pulmonale can occur in the chronic bronchitis in the severe case of chronic bronchitis? Because of hypoxia. Hypoxia leading to arterial pulmonary vasospasm, leading to increase the blood pressure inside the pulmonary vessels, causing right-sided heart failure. The clinical picture of the chronic bronchitis, as we said, persistent productive cough for 3 months in 2 consecutive years. The patient also complained of dyspnea, repeated lung infection, hypercapnia, hypoxemia, and cyanosis. Cor pulmonale may develop in long-standing severe chronic bronchitis due to hypoxia, causing pulmonary vessel spasm, with increased blood pressure inside the pulmonary vessels, causing pulmonary hypertension and right-sided heart failure. Expiratory air flow obstruction may result from airway narrowing, as in chronic bronchitis, bronchiolitis, bronchial asthma, and bronchiectasis, and also can occur due to loss of elastic recoil, which characteristically occur in emphysema. So in obstructive lung diseases, we have 2 main causes of expiratory airflow obstruction: airway narrowing and loss of elastic recoil. We will start pulmonary emphysema. The definition of pulmonary emphysema is permanent dilatation of air spaces distal to terminal bronchioles, including respiratory bronchiole, alveolar ducts, and alveoli, accompanied by destruction of the wall without significant fibrosis. Enlargement of air spaces not accompanied by destruction, we call it overinflation. So we have emphysema, which is permanent enlargement of air spaces distal to the terminal bronchiole, and we have another disease called overinflation, which is enlargement of air spaces not accompanied by destruction. This is a histologic definition. Emphysema is classified according to its anatomical classification within the lobule into four major types: centriacinar emphysema or centrilobular emphysema, panacinar or panlobular emphysema, paraseptal emphysema, and irregular emphysema. This is the normal anatomy of the distended lobule. The normal lung consists of lung lobules. This is a lung lobule, hexagonal in shape, containing 3 to 5 terminal bronchioles and 3 to 5 respiratory acini. The hexagonal areas of parenchyma, of lung parenchyma, each about 1 to 2 centimeter diameter, outlined by thin fibrous cells. Each hexagonal area called lung lobule, supplied by a lobular bronchiole that branch further into 3 to 5 terminal bronchioles, followed by 3 to 5 respiratory bronchioles bearing alveolar ducts and alveolar spaces. Here is a lobular bronchiole branched into terminal bronchioles, then respiratory bronchiole, then alveolar duct and alveolar sacs. This diagram shows the hexagonal area, which is the lung lobule containing 3 respiratory bronchiole which branch to alveolar duct and alveoli. The classification of emphysema, starting with centriacinar emphysema, affecting the proximal part of the lung lobule, which is the respiratory bronchiole, while the alveolar duct and alveoli are normal. The panacinar emphysema affecting the whole acinus, including the proximal and distal part. The distal part affecting the distal emphysema affecting the distal part of the lobule, sparing the respiratory bronchiole. In the irregular emphysema, the acini or the acinus irregularly affected. In the centriacinar emphysema, there is enlargement of the respiratory bronchiole, the central or the proximal part of the lobule, while the distal alveolar ducts and alveoli are normal. This type is very common in the upper lobe and associated with smoking. This diagram shows the affection of the respiratory bronchiole in case of centriacinar emphysema. Here the alveolar duct and alveoli are normal. The gross picture of the centriacinar emphysema showing dilated air spaces in the lung tissue, scattered dilated air spaces here. The panacinar emphysema, there is enlargement of the all acinus, including respiratory bronchiole, alveolar duct, and alveoli, more common in the lower lobe, especially in the anterior margin of the lung, and usually severe at the base of the lung, associated with alpha-1 antitrypsin deficiency. Pan equal to affection of the entire acinus, not the entire lung. Panlobular or panacinar, this diagram shows the affection of the respiratory bronchiole, alveolar duct, and alveoli. And here are the dilated air spaces much more severe and more dilated than the centriacinar emphysema. As we said, centriacinar is more common, about 20 times more common than the pan-acinar emphysema. In severe cases of centriacinar emphysema, the distal part of the acinus become involved and changed to the pan-acinar emphysema. The distal acinar or paraseptal emphysema, the distal part is enlarged, including the alveolar duct and the alveoli, while the proximal portion of the acinus is normal, affecting the upper half near area of fibrosis or lung scarring adjacent to the pleura, so can cause spontaneous pneumothorax in young adults. Appear as multiple enlarged air spaces under the pleura, causing what's called emphysematous blips or bulli, ranging in size from half to 2 centimeter diameter. The cause of paraseptal emphysema is unknown. This diagram shows the affection of the distal part of the acinus here, while the respiratory bronchiole is normal. Can occur in the upper lobe near area of fibrosis and also occur under the pleura, causing emphysematous bulli, as we see here, dilated air spaces under the pleural covering. Rupture of these spaces can cause pneumothorax. Irregular emphysema is a regular involvement of the acinus associated with lung scarring and fibrosis from a healed inflammatory process. The patient is asymptomatic and clinically insignificant. These are the 4 types of emphysema, starting with the centriacinar, which is the more common. As we said here, affection of the central part of the lobule, the pan-acinar affection of the whole acinus, the paraseptal affection of the distal part, the irregular emphysema, the acini are irregularly involved. The pathogenesis of emphysema is due to imbalance between proteases and antiproteases in the form of alpha-1 antitrypsin enzyme deficiency, increased proteases by chemoattraction, by smoke and other factors, leading to accumulation of neutrophils, macrophages, and lymphocytes secreting proteases and elastases. The elastase cause destruction of elastic tissue in the wall of the alveoli, and also destruction of epithelial lining of the alveoli and endothelium lining of the alveolar capillaries, causing loss of alveolar wall or destruction of alveolar wall, and also damage of mesenchymal cells, so loss of the ability of repair. The decrease of alpha-1 antitrypsin deficiency occur in pan-acinar emphysema. Its actual deficiency or functional deficiency by oxygen-free radicals, as in centriacinar emphysema due to the effect of smoking. So imbalance results and destruction occur. Genetic susceptibility also has a role in the pathogenesis of emphysema. The smoking and genetic predisposition cause recruitments of neutrophils and macrophages with the release of proteases and elastases. Also, the functional inhibition of alpha-1 antitrypsin decrease the effect of alpha-1 antitrypsin, so decrease the anti-protease effect. The release of oxygen-free radicals causing destruction of epithelial cells and elastic fibers in the alveoli, deficient counteraction by alpha-1 antitrypsin functional deficiency, more recruitment of inflammatory cells, Epithelial and endothelial cell injury, also damage to mesenchymal cells, leading to lack of extracellular matrix and the decrease of or loss of the ability of repair. The pathologic factors of emphysema. The gross picture showing the arrow shows the dilated air spaces due to destruction of alveolar wall, causing large air spaces. If these air spaces under the pleura, we call it emphysematous bully, like here. High power shows the dilated air spaces in emphysema. The microscopic picture, there is thinning and destruction of the alveolar wall. Here, destruction and thinning of alveolar wall with formation of large air spaces, and these are the remnant of the alveolar wall projecting into the air spaces. Cases of emphysema can associate with chronic bronchitis, fibrosis and chronic inflammation and around bronchioles can occur. The microscopic picture here shows the destruction of the alveolar wall with thinning, and this is the bronchus or the terminal bronchiole showing chronic inflammation associating with emphysema. So this is a case of emphysema plus chronic bronchiolitis. Secondary pulmonary hypertension developed in cases of severe emphysema associated with chronic bronchitis due to hypoxia causing pulmonary vasospasm and loss of pulmonary capillary surface area due to destruction of the alveolar wall. Both will increase pulmonary arterial resistance. Death in chronic obstructive pulmonary diseases occur due to respiratory failure, acidosis, hypoxia, and coma, or a right-sided heart. The clinical picture of emphysema: the patient complains of dyspnea, prolonged expiration, a barrel-shaped chest, and the ribs are almost horizontal in shape, weight loss, and hyperrespiration. Prominent sternoclavicular muscles due to increased use of accessory muscles of respiration. The shoulders are held high. The heart